can we zoom out a little bit from the trial here and say for a patient who has relapsed after 3 prior lines of therapy and comes back now with an aggressive presentation like this patient, what are the projected outcomes with the established therapies that we have in our clinic? Ajay?
I think this is a great example of how FISH may not encapsulate everything about a patient, because this patient, when was initially diagnosed, is intermediate risk. And here we are, within 1.5 years, this patient has gone through 3 lines of therapy. And I think sometimes we have to recognize as clinicians what's happening in front of us, which is, in some ways, at the bedside, going through many regimens in a short time is telling you that they're high risk. It doesn't matter what the pathologist is telling you. You know this patient's high risk, and I think that's an important consideration. But then the other feature that, with respect to, I think, the CAR T study that integrates this is it's really an unprecedented number of lines of therapy for this population, median of 7 lines of therapy. So on the one hand, they weren't high enough risk that they couldn't get 7 lines. On the other hand, it's a heavily treated population with it's an unmet medical need. So I think historically, Shaji Kumar had published in Leukemia, I think 2009, showing that double refractory patients had an expected OS of only 9 months, and that was at that time IMiD or PI. Now, of course, we have the CD38 also approved. But I think historically, in somebody who's had such short remission, this really is an unmet medical need, and there is no FDA-approved regimen for this patient that we are guaranteed to get benefit from. And then I think the only other point to make is, as we've said all along, I think all of us agree clinical trials are really always appropriate, but this patient's presentation brings up another issue, because we all know that, and this is true of the CAR T as well, there's a tremendous selection bias in CAR T, in the sense that from the day you sign consent to the day the cells are collected to the preparation of the CAR T and the infusion, we're talking 4 to 6 weeks. So when you have explosive disease, those patients aren't even getting signed. I think there's a real cherry picking of patients who can wait this period to get to the CAR T infusion. And I think that's important also when we're picking clinical trials, because this patient who has disease progression with bone disease, if you don't pick an active therapy, by the time you finish screening, start a phase 1 agent, possibly at a homeopathic dose level, this patient's just going to progress and have debilitating pain. So I think one regimen, if a study was not appropriate, that we use to rapidly debulk patients is the 96-hour regimens like DCEP, VD-PACE, so that you have a little bit of breathing room. You get them down. These regimens are not going to work forever, but if you debulk the disease and now you have a biochemical progression that allows you to enter a study, that's much better for this patient than getting in with such a high level of disease.
I would agree with that. Nina, what's your take on this patient?
Yeah, I think a lot of what Ajay said, I also agree with. One interesting thing right now, as this patient stands, I don't think would qualify for the CAR T because they have an ECOG of 2, and I think it's 0 to 1, and that's something else you have to consider. I completely agree with you that the most difficult thing about putting these people on this particular types of trial is that they have to really, you have to thread the needle. You have to be good, but not too good, and bad, but not too bad. And so these people, it's hard to know what would happen to this patient if they got a CAR T. Hopefully, if there's FDA approval at some point, we will know that better. In the absence of that, I think another important finding would be if we were to know if they had a translocation 1114 now. The FISH wasn't mentioned now because we could consider something like venetoclax, although that's off-label, as a potential sort of salvage regimen. Because with these types of patients, you're really grasping for whatever you can. And I like your idea about cytoreduction. And then while that's happening, potentially try to find compassionate use, some other drug or venetoclax, something like that. Because at this point, you really want to try to see if you can get quality of life, symptom reduction, disease reduction, and yeah, they may or may not make it to a clinical trial, but you want to do the best that you can possibly.